Good evening, delegates. On behalf of IACM Agra, I welcome you all in today's CME. This is the PACS Obstructive Airway Disease Symposium 2025, organized by IACM Agra Chapter, CDRS, IACM, ACP and Elite Group in association with PACS India. So, in next 2 hours, we will be covering latest update in COPD 2025, newer drugs and devices by Dr. Kanishk Kumar Singh. Another talk is latest update in asthma 2025 by Dr. Deepak Talwar. And what is Dr. Kalla.
थैंक यू डॉक्टर विश्वानी। मैं IACM की तरफ से आप सबका हार्दिक स्वागत करता हूं, स्पेशली डॉक्टर दीपक तलवार साहब की टीम जो दिल्ली से यहां आए हैं और हमको अपडेट करेंगे रेस्पिरेटरी डिसऑर्डर्स पे। वी बीइंग ए पार्ट ऑफ ए क्लिनिकल एसोसिएशन, वी विल लाइक टू स्टार्ट विद little bit radiology clinical, and for this I am happy to invite Professor A.S. Sachan, who is Professor Head TB Department at St. Medical College, now retired but still active and working like anything. He is said to be master of radiology, and I will invite Dr. Sachan, please come and discuss 2 or 3 cases radiologically. हम एक्सरे में क्या चूक करते हैं, कहाँ भूल हो जाती है और क्या क्या मिस्टेक्स होती हैं जिनको हमको नहीं करना चाहिए। प्लीज गिव हिम ए बिग हैंड। एट द एज ऑफ अबव 80 ही इज स्टिल मोर डायनेमिक देन अस। टॉर्च पॉइंटर है क्या? पॉइंटर प्लीज, पॉइंटर है? माइक भी है? माइक ये नहीं चाहिए, इसमें लगाएंगे? नहीं, वहां से नहीं लग, वहीं से चला दो। हाँ चला दो, हाँ हाँ तुम चला दो। सही। ये माइक, कॉलर माइक है क्या भैया? कॉलर माइक, हाँ हाँ दे दो। कौन सा जाएगा?
Hello. I welcome you all. It is my pleasure to be a part of today's presentation. This X-ray represents mediastinal in the superior mediastinum, where in the lung fields we find many multiple rounded shadows of variable size. So that is the classical description of dense radio-opaque circumscribed opacities of variable sizes, very much fits in with the diagnosis of cannonball shadows and the age of this patient is about 65 years of. So at this age, it is important. The right paratracheal lymph nodes could be there. Lymph nodes may be secondary to the bronchogenic carcinoma on the left side and producing lung-to-lung metastasis. Possibilities of multiple cannonball shadows, which are more denser than this, absolutely circumscribed, very densely radiopaque, or multiple hydrated cysts, or other possibilities, granulomas of the lung. So, history, presentation, X-ray, and the CT findings will confirm the diagnosis. Can I have the CT findings of this patient? Pointer है क्या? This is an this case presents primarily the abnormalities seen here are ground glass or soft homogeneous, non-homogeneous opacity in the bilateral lung fields all over, predominantly in the mid zone, slightly lesser on the upper zone and lower zone. In this situation, with the history of short duration, it is or hypersensitivity pneumonitis. Though pneumonia bilateral is the most common presentation in this film. Can we have the probably the same patient after a couple of days, more obvious the you change the stick to one case. In this case, there is right paratracheal opacity, which you don't see on the left side. Tracheal opacity and hilar and parahilar increased so-called circumscribed opacities, probably mediastinal adenopathy. This has to be confirmed on film or HRCT. Yeah. So the HRCT shows increased hilar shadows, much better in the lower cuts, and some opacities are also seen on the right side. So these are probably lymph nodes. Causes of lymphadenopathy is all well known to you. In young adults, tuberculosis, lymphoma, later in other ages, sarcoidosis, the three main common causes of Next. This is the same. Next. ये तो हो गया. Yeah. In this X-ray, there is congenital anomaly. First and second rib are showing exhaustosis of the rib, are practically approximating to each other. This is exhaustosis of the rib, congenital anomaly, has nothing to do with the symptomatology. Then a patchy opacity in the lower zone, maybe subsegmental pneumonitis. Causes could be, first of all, a pyogenic infection or mixed bacterial infection. In diabetics, sometimes lower lung field tuberculosis is also known in diabetes as well as in other immunocompromised hosts. The lower lung field tuberculosis is also a well-recognized entity. So, to start with, first, just pneumonitis, exudative tuberculosis in compromised hosts. The investigations has to be done accordingly. Can we have this HRCT? Yeah. The same visualized very well. Along with this, there are other few opacities on both the sides. So this is pneumonitis involving both the lungs rather than just one on one side. So HRCT revealed bilateral lesions, which is more likely to be pneumonia. That's all. Thank you very much. In a nutshell, one should not go directly into the lung fields. A proper systemic visualization and appreciation should start from soft tissues, mediastinum, then the lung fields in all the zones, upper, mid, and lower zones, levels of the diaphragm, contour, and this represents so many things which are expected to be correlated with the symptomology and with the
Dr. Deepak Talwar and his unit for long time. They are doing wonderful job in Delhi and NCR Delhi. Rather, he's catering the patients all over North India. His life is for chest infections, chest diseases, CA bronchus, sarcoidosis, and quite a few number of patients in Agra are still in his treatment. He's a wonderful person, very helpful, very knowledgeable, and very. He runs ICU as well. So any patient with chest diseases, with ICU admissions, this facility is also available at his center. Now I will request to his teammate, Kanishk Singh, to start his deliberation. Thank you.
Thank you, sir, for the wonderful introduction. And this already been said with a beautiful radiological discussion which we had just a moment before. So today actually is a very special day, and which I have not told to anybody else also. I lost, but that didn't let that happiness of coming to Agra down. And I was excited throughout, before coming to this place, and I have deliberately asked my seniors to during my presentation. I was really, really happy. You will understand why. Can I have my जो भी करना है करो, या तो इसी लैपटॉप में लगा दो, या तो इसी लैपटॉप पे लगा दो ना, दूसरे वाले लैपटॉप पे लगा दो, इसमें कर दो जल्दी से, इसमें नहीं है, पेन ड्राइव है ना, पेन ड्राइव डली हुई है, हाँ उसमें लगाओ जल्दी, लगा, इसमें डाल दो, हाँ इसमें तो साउंड भी आएगा ना,
हाँ आएगा सर।
Yeah, now we are all set, yeah. So I was talking that today's lecture is very important and you will come to know why I'm saying so. But before we start, as we all know, Agra history, and the history is celebrated throughout India, not only India, but throughout the world as well. We too also have a history, as we all know that we did our mini PACS last year on 8th of August in this hotel. We have a lot of memory, very beautiful memory, and a lot of photographs. I have put some photographs over here. So PACS and Agra has a journey together since last 1 year, and still the journey is continuing. I'll be talking about a special milestone, as must be seeing that on the left side, there is written a special milestone line, and this milestone will also be converted into the history, for me at least, that this meeting marks my 100th lecture as a faculty in national conferences. So that is why I did. But more than that, how it all began. It all began because of my mentor, because mentor is someone who sees more talent and ability within you than you see in yourselves, and helps bring it out of you. Perfectly correct when it comes to my life, because in 2022 when I came to Metro Center for Respiratory Diseases, this is my Facebook post, you can see the date, it was 26th December 2022, and this was the time that I am not capable enough, I don't know a lot of things, I'm not confident enough to stand in front of all of you. So whatever I've done and achieved till now, and I'm standing in front of you, it's because of my mentor. He didn't knew about these slides also that I'm going to present, but you to please stand up and give a big round of applause to Dr. Talwar because of his contribution to pulmonary medicine and the legend he is. And we are all very fortunate that he is sitting with us. So I request Dr. Talwar sir to come on the stage and say some lines, and then only I'll. Sir, please.
I think it's almost like a crying moment for you. It's for me, basically. No, it's okay. So if I can have a hand mic. Yeah, hand mic. Where is the hand mic? Hand mic is not here. Yeah, give me a hand. Yeah. So obviously whatever Kanishk said is a very, very but more important than that, today is my 25th year when I first came to Agra as doing my first CME in 2000. And we have completed 25 years. And today, this CME to be a little special because I wanted physicians, I wanted chest physicians, I wanted critical care physicians, I wanted interventional people, everybody, because everyone has grown into different directions over the last 25 years. It wasn't like that. The first person who was of my first lecture which I took on asthma was Dr. Gopi. And he is still sitting there with his cap. He just looks the same as he used to look 25 years ago. And the second is Dr. Subhash. And Dr. Subhash made me meet with so many people at that point of time that I was overwhelmed. No words to express my thanks, my gratitude, and in-depthness for the rest of my life, because whatever I am in this 25 years, it is because of Agra. It is because of Agra. I know that people tell me that I am a house because everybody knows the neighbor that, okay, my relative went there, this, that, all those stories are there. But more important are the stories made by people who are sitting here and giving me all that faith that I developed this center with Vipul, which is sitting here, with just 2 beds. Hospitals, 2 beds. And Vipul was a senior resident in cardiology whom I had to hire to work in respiratory medicine. Today, we have 60 beds and we don't have even single bed available, in contrast to the rest of the metro hospital, because we have outgrown whichever was possible in the last 25 years. It is because of the support of everyone who's sitting here today, because I do remember when I joined Noida, I was told that you are not a person from Delhi. You remember, Vipul? You are not from Delhi, you are from Uttar Pradesh. From Uttar Pradesh, I will prove that I am from Uttar Pradesh, worth it, and I will never ever do a single CME in Delhi. I will only do it in Uttar Pradesh. And 20 years I stuck to that, and every time I was asked to come to Delhi, I said, no, I don't want to come to Delhi. And I will do it, but I will not go to Delhi. Because there was so much of discrimination between Delhi and the rest of the world, as if everybody in Delhi knows everything and rest everybody is like useless. Absolutely. I think we proved that collectively, and of course with the help of in here, that in UP we could do wonders. It's not a question of, that we don't want to do it, but we are overwhelmed. This is not the kind of cases and the kind of things which come to the rest of the world. It's totally different. We managed it. We managed it so well that today's CME, gratitude. It is my gratitude to each and every physician of Agra who has helped me in a way where I have reached today. It's entirely because of you. Thank you very much. And I would like Kanishk to continue. Thankful that there are people who think that I am a mentor. I've always wanted to be a mentor. I always wanted to be a teacher. And let me tell you, I was in practice only by default because PGI decided that perhaps if they had to choose one among the two, I was the one who was left behind. But I, in practice, that today my mentor tells me that nobody could have done what you have done in private practice. So I think that itself shows that I needed help, I needed people, I needed support, which entirely came from Agra only. So thank you, Agra, for doing this for me.
Thank you, sir. So now I'll proceed with my lecture. We'll be honoring the past, celebrating the present today, and shaping the future, just like Agra and just like PACS. So before we move on to further discussion, there needs to be a discussion about the change in the shift of the landscape of the COPD in terms of its prevalence and in terms of what are the innovations which is needed because of the rising cases due to pollution, occupational hazards. As we all know, it's the third leading cause of death worldwide, and all the admissions which are done due to exacerbation of COPD leads to a lot of cost burden on the family of the patient and the family of the patient as well. So that is why the innovation, because current therapies have limits. There are poor symptom control, frequent exacerbations. We need smart inhalers, and we need the help of AI for monitoring purposes as well. The treatment should be personalized and given to the patient, monitored frequently, caregiver and the physician as well. So we will be discussing about the newer diagnostic tools, the changes in the GOLD's 2025 report, the role of interventional pulmonology when it comes to the treatment of COPD, is if there is any, we'll discuss that, and the further about, we'll be discussing about that as well. So first, the newer innovations in the diagnostics. We all know that impulse oscillometry, I don't think it's a very unusual term for any of us right now. So it works on the principle that sound waves are pressure waves, and when goes inside during the tidal breathing of the patient, that gives us information about the consistency, the pressure, the impedance, and the reactance within the lung parenchyma and the airways. Here you can see in the graph, the sound waves are going through. The patient is having a normal tidal breath. FOT, the frequencies vary from one attempt to another. In iOS, all the frequencies, different frequencies goes together. And the concept comes that smaller frequencies like 5 Hertz, which is given to the patient, goes farther, reaches to the smaller airways, 23rd generation. And the 20 Hertz frequency, you can see, doesn't go beyond the large airways. So when you subtract this area of R5, which is a 5 Hertz with a resistance at 5 Hertz, minus this 20 Hertz, then you get this resistance in the smaller airway. Remember this, it's very easy. You can see that the wavelength of the red light is very high. So the wavelength is high, then the frequency is low. We all know that red light travels farther. So lower frequency things always travel farther. So the frequency at 5 Hertz will be going towards the end, that smaller airways, and the higher frequency, which is the 20 Hertz, will not be going further than the larger airways. For interpretation, we need to calculate the impedance. Impedance is what? Resistance plus reactance. In the normal airways, there are normal resistance and normal reactance. Alveoli are damaged, then the normal resistance will be normal, and there will be elevated X5, which is the reactance. In airway obstruction, there will be elevated resistance and the normal X5. But if both are damaged, then the both will be affected. So reactance is mostly affected when the damaged and the airways are damaged, then the resistance is affected. So you can see on the left hand side corner, there are the reference values for the adult currently used in the Indian scenarios. Maybe sometimes later on they can change, but this is the standard which we have developed in the recent system. And For interpretation, we need to know what is AX. So AX is the frequency at which the resistance becomes normal. The inertance and the capacitance of the lung become normal, which is called as FRIS, and the area which is formed due to this is called as AX, which is the reactance. If you see the resistance, then you can see that on the large airway obstruction at 5 Hertz and at 20 Hertz, everything will be the higher side. In normal airways, everything will be in the lower side. But in the smaller airway obstruction, R5 with resistance at 5 Hertz, this should be higher, and then rest of the values will be normal. So when you subtract R5 minus R20, you will get a very significant value which you can compare with the data which was available in the previous slide. So this is, for example, this is the patient spirometry reports. I am putting it simultaneously. You can see that FEV1 by FVC is 79.14 in this patient, and FEV1 is 87%. We cannot, comment on the small airways, but when you see that iOS, the Z is 206, which is suppose we keep it at 150, which is higher. So either resistance and reactance is affected. So R5 we keep it as around 150, so it is higher. R20 is normal. So the frequency which is going to the larger airways are normal. So if you subtract that, then the value gets very significant. And AX is the area of reactance, which is 79. Normally we 40 in Indian scenarios. So this patient is bronchial asthma and having a small airway disease. So what's the importance of small airway disease? Why are we talking about it? We published one data in Monaldi Archives of Chest Diseases recently, and the study was done in around 2017 and 2019, which showed asthmatics, when we prescribe the drugs, 1/4 of them do not respond, maybe because of small airway disease, and in such situations we provide ultrafine inhaled corticosteroids to this patient. But before that, we have to diagnose small airway disease in such patients so that we can think about different scenarios before even thinking about biologicals, I must say. So, but this topic and this platform is about COPD. So what's the role of iOS in COPD? Recently it is studied in 2024 and published in BMJ Open that in COPD patients have a role of impulse oscillometry, because in R5 in COPD has higher values, R20 is elevated, R5 minus R20 is greater in COPD patients when compared to the asthma patient, indicating the peripheral airway resistance. Reactance is more negative in COPD, reflecting reduced lung compliance. The area under reactance is increased in COPD. This was study which was done. The area under the curve was for R5 minus R20 was 0.75, which is above 70%, showing that iOS is a significant instrument when it comes to the diagnosis of COPD and small airways in the patients, a large number of patients, which was 307. Now we'll come to our second part of the topic, which is what are the changes the GOLD has done in 2025. So we'll be talking about a few, which is related to our topic about COPD and the newer devices and innovations. The patients who are taking ICS-LABA, the role of defined very clearly through a flowchart, which we'll be discussing now, and ensifentrine and dupilumab has been added. Of course, they are not yet available in India, but in recent times, or in a couple of years, we'll be definitely seeing very frequent use of all of them and talking very frequently about them. The next is an impact trial which focuses on the mortality when you compare the triple therapy with the dual therapy. So first is management of patients currently on ICS-LABA. The patient is already taking ICS-LABA, and there is no current exacerbations, and previously had exacerbation but responded to LABA and ICS, then you can continue the treatment. Maybe I consider that the patient is not correctly diagnosed with COPD. Maybe the patient might be having asthma, or the component of asthma is involved in the patient at that point of time. But if the symptom load is high, then you have to consider for LABA in this patient. And if the patient is having no relevant exacerbation history, then also consider the changing from LABA ICS to LABA and LAMA when you have diagnosed the patient as COPD. But if the patient is having current exacerbation and the blood eosinophil count is more than 100, to LABA-LAMA ICS, which is the triple therapy. If less than 100, then you can shift the patient to LABA and LAMA. Now, what is ensifentrine? It's a simple drug which inhibits PDE3/4 and PDE4/3 and 4, and which leads to the increase in CAMP and CGMP, which leads to providing with the bronchodilation to the patient. It's very easy to use, 5 to 7 minutes with the help of a nebulizer. So yet it's not available in India, but yes, that will be coming soon, I assume, and I hope that it comes very soon, which is the medical management which has been added in Goal 2025. Next is dupilumab. This first and only COPD. I'm sure that in a couple of years, Dr. Talwar sir will be talking about dupilumab very often when it comes to asthma and COPD. It inhibits IL-4 and IL-13. In 2 of the trials, there's a Boreas and Notus trial that has shown a significant reduction in when it comes to exacerbations of the patient. The dose is very simple, every 2 weeks if the patient is fit for dupilumab. Then comes the role of IMPACT and ETHOS trial, which I was talking when we compared the triple drug therapy with the dual one. We saw a significant result and significant decrease in exacerbation of the COPD patients. For the Kronos trial, it's a 4-week run-in period. The patients were randomized into 4 categories. First was the patient were taking Breztri, which is budesonide, glycopyrimidine, formoterol. Next, the patient were glycopyrimidine, formoterol, MDI, then budesonide, formoterol, MDI, and fourth label budesonide, formoterol, and DPI in the DPI form. The population selection was showing that there is no requirement for a history of COPD exacerbation in the past 1 year. Let's see directly the results. Here you can see the exacerbation reduction when it compared to LAMA and LAMA, which is a dual therapy COPD that showed, Breztri showed 52% reduction when it compared to the dual bronchodilator. NNT was 3. That means you need to treat 3 patients to prevent 1 exacerbation of the patient per year, which is very good and significant, I must say. Only 3. Now, ETHOS patient were randomized into 4 categories. Similarly, Breztri were one of them. The patient selection showed that symptomatic patients were selected moderate to severe COPD with a history of moderate or severe COPD exacerbation within past year. In Kronos, there was no history of selection for the history of which showed a significant 20% reduction when it compared to ICS LABA therapy, and the NNT was 31, which is you have to treat 31 patients to prevent 1 COPD hospitalization or exacerbation. Now, this is not a direct comparison, wise to comment, but when you compare the NNT of 2 different trials, which was the IMPACT, fluticasone, umeclinidine, and vilantrol, as compared to Breztri, then the NNT was 80 when it compared to 121 of IMPACT study. So also very much useful because that was also a triple therapy, but there is no head-to-head trial, so it's not very wise to comment. But yes, when it comes to NNT, it showed a better NNT than fluticasone, umeclinidine, and vilantrol. Let's see how the inhaler looks like and what are the significant changes in the inhaler which has been done for the betterment of the patient. Can we have the...
These particles then act as vehicles for the drug crystals.
So we'll videos now, 2-3 videos for the better understanding of the topic which I am going to speak. And if there was a sound...
Formulate.
Yeah, you can slowly increase the sound if you can, slightly.
Proportions for a consistent dose in both dual and triple formulations. These particles then act as vehicles for the drug crystals, limiting drug-drug interactions in the And the crystals remain attached to the particles after actuation to ensure effective, consistent delivery to the whole lung. Effective, consistent delivery is crucial for inhaled therapy to have maximum impact. Drugs need to be deposited throughout the whole lung, as target receptors are located in a non-uniform way throughout the large and small airways. The light aerodynamic particles of the aerosphere delivery technology act as vehicles, delivering the drug combination through the whole lung to small airways. As the porous particles are made of phospholipids, a component of lung surfactant, they disperse effectively, depositing the drug combination on the airway surface. Aerosphere delivery technology provides
47.0 to 54.1% lung.
As well as ensuring delivery to the whole lung, aerosphere delivery technology provides consistent delivery. The particles easily form a stable, homogeneous suspension inside the device, which ensures a consistent dose over time, even when handling errors are applied. Unlike in other PMDIs, where crystals can separate rapidly after shaking. Hence, the technology provides consistent drug delivery with minimal shaking, consistent drug delivery even with a delay from shake to actuation, and consistent drug delivery throughout the life of the device to ensure delivery of the right dose, every dose, from first to last inhalation in a pressurized metered dose inhaler that most patients are already familiar with.
For the revision, it has a foamy particle. Size is very optimum, around 3 micrometers, and all the 3 triple inhaler drugs which are used gets attached to that foamy structure, and there is no drug to drug interaction, and other benefits like unique, unlike other PMDIs, when you shake it and take it after 10 seconds or 20 seconds, then the effect is not the optimum, but that doesn't happen with Aerosphere. So definitely in 8 or 9 steps of taking an inhalers, Bristry helps you to minimize 1 or 2 wrong steps which the patient takes generally. Of course, I consider it slightly better suited to the Indian scenario as well. Now, is there any role of intervention pulmonology? Of course, we know that there are role of surgical intervention in COPD, the lung volume reduction, but can it be done by interventions? Yes, of course, there are they're not available and they are under clinical trials right now, but we need to know what are those. The first one is bronchoscopic thermal vapor ablation, in which you give a certain joule of heated vapor that leads to the fibrosis of the lung, which ultimately leads to the reduction of and less residual volume in the patient, and ultimately leads to the improved quality of life. I'm just going to show the video so that it's very easy to understand.
Lung segments can become diseased and hyperinflate. The thorax remains expanded and the diaphragm remains flat. This increases resulting in reduced pulmonary function, physical capacity, and quality of life. The reduction of emphysematous hyperinflated segments with BTVA, bronchoscopic thermal vapor ablation, can improve pulmonary function in patients with or without collateral ventilation. BTVA is the first person emphysema that allows targeted treatment of a patient's most diseased segments while sparing healthier segments from being unnecessarily reduced. A BTVA vapor catheter is bronchoscopically guided to the diseased segment, and a precise, patient-specific dose of vapor is delivered. This painless vapor dose is delivered in 3 to 10 seconds, resulting in ablation of the targeted disease parenchyma, followed by a normal biological healing process. This results in gradual volume reduction occurring over several weeks, significantly reducing the risk of pneumothorax. Inflated segments allows healthier segments to expand, the thorax to retract, and the diaphragm to unflatten, reducing residual volume, improving FEV1 and SGRQ. BTVA has been proven to benefit patients with or without complete fissures and Non-implant therapy is not subject to the potential long-term complications imposed by implants, and BTVA can be considered for additional therapy for continued lung improvement and quality of life over time.
So this was a BTVA procedure. Now we're moving on to the next procedure.
For severe
The endobronchial valves. Luckily, I got a chance to go to Heidelberg, and I had seen a lot of patients coming, every day of the endobronchial valves. Mostly they were coming for the removal because that's the most common complication of the, displacement of the valves. But yes, this is a procedure which say that they get around 30 to 40% results in the patients of COPD when it's come to the quality of life improvement and FEV1 improvement. So it has a valve-like mechanism. Only the air which is there in the residual lung as a residual volume, that comes out, but the air doesn't go when you inhale the air from outside. So let's see the small video for endobronchial valves.
It's a proven, minimally invasive treatment designed to improve breathing, activity, and quality of life for emphysema patients who are breathless despite maximum medical therapy. Procedure is performed under general anesthesia or conscious sedation, where a standard bronchoscope and flexible delivery catheter are used to guide the valves into the target lobe and desired airway. Multiple valves are implanted to ensure complete occlusion of all airways leading to the target lobe of the lung. Valves may be placed at the lobar, segmental, or subsegmental levels, dependent on the airway anatomy. Trapped air in the treated lobe escapes through the Zephyr valves until the lung volume of the treated lobe is reduced. The valves can be removed and replaced if needed. Remaining lobes can expand more fully, and pressure on the diaphragm is relieved, improving breathing mechanics and overall lung function. Patients who respond to Zephyr valve treatment often experience meaningful improvement within 45 days. The Zephyr valve is tropic emphysema treatment proven in multiple clinical trials to deliver clinically meaningful benefits across several important patient measures: quality of life, exercise capacity, dyspnea, and lung function. With thousands of patients treated worldwide over the last decade, valves are intended to be a long-term solution to help emphysema patients breathe better, do more, and enjoy a better quality of life.
So this was the role of interventional pulmonology when it comes to the treatment of COPD. Now we'll move on with some small innovation happening in the world when it comes to inhalers. So I was going through one of the website, which is Airway, helps to adhere the patient to the inhalers with the help of applications, mobile apps, which is connected to the physicians as well as the patients as well as to the care. The patients are able to monitor their treatment and their inhaler doses. ResMed is also doing a lot of quality work when it comes to digital health, so the patient get all of the data when it comes to sleep study, the CPAP use, and that data is simultaneously shared as well. So this was my time. Thank you so much, everyone. We have our main event, that is PACS 25 in August 15, 16, 17. Thank you so much, everyone.
Thank you, Dr. Kanish, for very descriptive overview of recent advances in COPD, both medical and interventions. I request you to take the seat on the dais for question answer session. I invite Chairperson, Dr. Please come and take the seat on the dais. I request Dr. Gopi Chand Gupta, please come and take the seat on the dais. And our panelists, Dr. Rajiv Kishore and Dr. D.P. Agarwal. We will be having a brief question answer session, and after that we will proceed to the second talk. Thank you.
Thank you very much, Dr. Kanishk, for giving us idea of recent advances in COPD.
Thank you, sir.
The recent advances, they are mainly related to reduction in the volume, which is not contributing to function. And last night, when today's CME was due, so I thought I should talk to my son and what recent advances he's doing in Manchester Royal Infirmary. And believe me, that moment he was preparing to implant a valve in emphysematous bulla in chronic bronchitis, which is a common association, emphysema plus chronic bronchitis, to reduce the volume of the lung. I said, I haven't heard at Agra, but surely, recently we will come to know that Dr. Talwar is reducing the volume of COPD lungs. Then he also told me few things more. I said, don't talk about these valves and everything, and just talk to me about latest pharmacotherapy in management of COPD. So he came out with one drug, he said is doing wonders, reducing the inflammation of the that was roughly last. I don't know, I never heard of it. Phosphodiesterase 4 inhibitor, he said. And I don't know how much does it work. Dr. Gupichan?
I think in patients who have a lot of secretions and inflammation, it does work. But you have to be very selective with the choose to give it to. That's one thing. I think also for inflammation and where the secretions are a lot, azithromycin might also be a choice.
And it's an add-on therapy, not all alone it doesn't work. LAMA, ICS are not working enough, then you should add this drug. And second drug he told me was dupilumab, which Dr. Kanik already told about that. Else he was telling me, I don't know, to reduce the volume of the lung, besides putting the valve. I don't know. Sorry? Might be, because I never heard of it before, so vapor. I think so these are some latest advances going on in COPD. And are you doing it at Noida Metro? Not in India. Then I'm happy to know doing it. That's all. If there is any question from the audience, please.
Of course, the drug delivery, which has been shown in the results, is much higher with the breasttree, especially the inhaled corticosteroid part, ICS part, which is the deposition is around 50%. Generally, it is around 20 to 30%, which I know. So that might be one of the biggest reason for the decrease which was seen in the Chronos and Ethos trial. So definitely it has a good lung deposition, maybe because of the size, maybe because of the technique which have the foamy structure, the lipophilic structure which they are using. And of course, it is also decreasing the, the errors which is used, done by the patient inhalers, at least omitting 2 to 3 steps because of the uniform distribution, distribution of the drugs to the smaller airways, especially ICS. I think this is the reason I think breasttree is on paper showing superiority when it compares to the other DPIs and MDIs.
So the reason is lipid molecule. It is made of fat, it is lipid. And lipid, we know that the respiratory epithelium actually is the one which gets the lipid attached to it. So on this lipid molecule, ICS, LABA and LAMA, all three have been attached to it. And molecule, which is 3 micron in size, so it is going to get into all airways smoothly. It goes, sits on the respiratory epithelium. Because it is lipid, immediately the message will go that it is attached to the respiratory epithelium, and because of its lipophilicity, the whatever to it, they are able to get and gain inside the respiratory epithelium and straight into the airways. So that's the basic theory why it works better than something else, because we know all inhalers give us about 20% deposition in the lungs. It is giving up to 50%. Primarily reason is because the particle onto lipid molecules, and these are the lipid aerospheres are nothing but lipid molecules, basically lipids. I would say particles, lipid particles.
It is like drone delivering.
It is like
drones.
a drone.
Yeah.
Correct. It's like a targets which have been, just went
Guided
and
missile.
goes and onto the respiratory epithelium. Sorry, yeah. So it is used without spacer because the speed is like that it does not require a spacer at all. And spacer is given for 2 reasons. One, if it's a very fast speed, you want to reduce the speed. Second, for all the mistakes you do. Basically, you are not able to charge the inhaler and then start the inhalation. There is a delay and things like that, and inspiration not taken complete. So all those things which happen are taken care of by this, in which even in that first 10 milliseconds, if you don't inhale, still the drug will be able to get inside the lung. So that's what I tell, that some of the mistakes which we do with PMDIs are compensated in this particular inhaler. But all the studies which were done, they never had any spacer along with it. So hence the spacers are not given.
2 small clarifications. There were some trials before of use of benzoyluramab in acute exacerbations, number 1. And number 2, how do you really decide, because the cases you get, not many of them are pure COPD, not many of them are pure asthmatics, that overlap, how do you decide the overlap part? Whether it's a case of really it's a mixture or it's a, what's a prime consideration to decide whether it's a mixture of COPD, whether it's overlap or it's a pure COPD?
I think the history comes, plays a very important part. But yes, overlap cases at our center, we have very less overlap cases, I must say. We generally either asthma or COPD. Overlap is very less. Of course, there can be remodeling in asthma as well. So sometimes it gets complicated in the diagnosis. Spirometry in COPD also shows sometimes reversibility. But if the reversibility is very significant, and if there is history which is suggesting, if there are nasal polyposis, all these things are there, then, and smoking history is of course very significant. But yes, asthma is something which we need to rule out before labeling it as COPD, which is a must, I must say, because the role of inhaled corticoids comes
just
in.
a few lines for Professor Sachan. He showed 3 patients with mediastinal lymphadenopathy. Of course, the differential diagnosis goes tuberculosis, malignancy, histoplasmosis, sarcoidosis. But as a physician, we stand just there. Whether it is sarcoidosis, it is tuberculosis, it is histoplasmosis, it is CA bronchus, or it is secondaries. So for that, we need endobronchial ultrasound guided FNAC. Unfortunately, in Agra, no chest physician is doing. It's a good information for we all physicians at Agra. Dr. Talwar, I discussed it a few months ago with him that are you doing it? He said yes. For a long time we are doing it. So to know the exact diagnosis of mediastinal is differential diagnosis, everyone knows, but how to reach up to the diagnosis. Dr. Talwar is doing EBUS for a long time at Noida Metro. I think I'm right, Dr. Talwar.
Thank you, Dr. Subhash. Actually, we got these India, which was in 2012. So we are doing from 2012, and I think we have done 5,000, and Deepak has done more than 3,000. He's single man who has done more than 3,000 EBUS actually at the center.
It's a very, very informative investigation, very informative. Because clinically, most of the time it becomes differentiate between sarcoidosis, tuberculosis, histoplasmosis. They all take the same way as the tuberculosis. And we have to rule out the malignancy as well. Luckily, we have PET scan, but malignancy is not the only one answer. But there are a few other diseases which causes mediastinal lymphadenopathy.
My experience is very different to yours. I think.
Yeah, the role of benralizumab.
Sir,
yeah, I think there is a role.
I will discuss this in my lecture, sir.
Yeah.
So,
I
Dr.
think
Prasad,
my
just one
experience
question.
very different. I think
Few
there's a
basic
lot of
question.
overlap compared to what you're saying that you have pure COPDs and asthma. I think there's a lot of overlap.
We generally,
Asthma and COPD. There's
Just,
a lot of overlap.
Just few questions, just one question. One is the lung exercise. In COPD, already lung is hyperinflated. So will you advise respiratory exercise?
yeah,
Basic question.
of course. Pulmonary rehabilitation is very, very important because, the muscles, involuntary muscles are of course very important for, breathing, but voluntary muscles are also very important. And when you have a strong voluntary muscles, which you can develop in pulmonary rehabilitation, then definitely rehabilitation is a must for all COPD patients.
And second is, in cases of COPD, most of these are bronchiectasis and fibrosis. So how the aerosols will help in this?
Why do you what?
Bronchiectasis and fibrosis in COPD.
Yeah.
So these your inhalers and how will they help?
They reducing the inflammation, and of course bronchodilation cannot be much because of course there is already dilatation because of the bronchiectasis, but helps you to prevent the inflammation part, and the further exacerbation is reduced because of the medications.
What?
We are not yet using dupilumab because it's not yet available in India. But definitely, I had a discussion with pharma people that when it can come, they are assuming, I must say, that it might come in late 2026, but it's not yet there in India. We had a discussion with Roland Bull also, and he's getting good results, approx 40-50% results when it comes to this biological. Expecting by end of 26 maybe. Yeah, maybe because of the inflammation, and that is leading to the inflammation. Maybe.
Thank you, Dr. Kanish, for wonderful talk. And I thank all the chairpersons and panelists, Dr. Subhash Chandra, Dr. Rajiv Kishore, Dr. D.P. Agrawal. And for the next talk is on latest update in asthma 2025, and the speaker is none other than Dr. Deepak Talwar. For this session, I invite my teacher and mentor, Professor Dr. A.S. Sachin. Please come and take the seat on the dais as chairperson. I invite the panelists, Dr. Sanjeev Anand and Dr. Rajesh Gupta. Professor Dr. Rajesh Gupta, please come and take the seat on the dais. I request chairperson, please introduce the speaker and start the scientific session.
Thank you. To introduce Dr. Deepak Talwar is a Herculean job. It's difficult. If I really start narrating his all awards and achievements and what he has held till date, it will take not less than half an hour. So The entire audience is very well knows very well to Dr. Talwar. In short, I will say, whenever our Prime Minister Modi ji comes for any speech, he requires no introduction. Likewise, Dr. Talwar, the Prime Minister of Pulmonology, at least in India, needs no introduction.
Dr. Sachan, you made my day today. I have grown seeing you teaching as you taught today, X-ray, because at that point of time, X-ray and CT scans were something which were only things to be learned for us because we had nothing else at that point of time. And I do remember 85, 86, when the CT scans came, it was like a boon to us that now much more than beyond these X-rays, and it became an art of teaching how to read a CT scan, because even the radiologists were not sure of what the CT scan means. Then they became masters, but as history repeats itself, now the pulmonologists are reading the CT scans better than the radiologists, seeing the patients in that clinical aspect. So great for that, sir. Thank you very much. I have been always an admirer of you. And when you were showing the X-rays, I was like reminded of my own days of my college, which was way back in 1980s when we were taught like that. Thank you for keeping that teaching spirit high. Very important thing today, because we forget that teaching is the most important part of it. Be in public, be in private sector, it does not matter. You can do wherever you are, and you can provide that. I'm going to talk about latest in asthma 2025, and that's the sad part of the story which I'm projecting to you today, that 40 people per lakh population of India, and we know that 1.5 billion we are losing their lives because of the diagnosis of asthma going haywire. So asthma is killing so many people in India despite the which is available, and is available with us for the last 25 years. What's happening? Why is this situation getting so bad? Obviously, the classical teaching and as well as the guidelines which tell us to treat asthma with inhaled corticosteroid and a LABA now has not worked. And it has led to failures where perhaps we do realize that asthma is a heterogeneous disease. One asthma in one individual is not same asthma in another individual. It's a heterogeneous disease. And what we are medicine is trying to give one size fit all strategy to all the patients of asthma, ICS LABA, whether it is salmeterol fluticasone or it is formoterol budesonide for each and every patient of asthma. And that has led to failures. So we are moving toward the new century, in the new era, with what is called as precision medicine. And this picture clearly tells you that in traditional medicine, same diagnosis, same treatment. If it had to work, it would have worked. It didn't. So it only showed that heterogeneous disease tries to find out where precise that this drug will affect this particular person in a good manner with a good positive outcome, and I'm going to use that. So whenever you give same medicine to this heterogeneous group of people, you can see that you can have positive effect and no toxicity. And this is the, the circles, which is clearly what we want for every patient of that disease. Be it asthma, be it COPD, be it lung cancer, interstitial lung disease, diabetes mellitus, every disease has the same problem. But there are people who will have positive effect, but to be toxic. We don't want that. We know that how many people on standard treatment of asthma do develop side effects. Then we have some people who have no effect and only toxicity. You want really that we should be able to identify and give them no treatment at all. What is the standard treatment which we offer to all? Effect, no toxicity. You give them, they don't get any benefit, they don't get any toxicity, but they continue to suffer. So in precision medicine, we will be choosing only this green group of individuals in whom it will have positive effect and no toxicity. How do we do that? It is by precision tries to realize that a disease requires to be split into various treatable traits. You identify a trait and you treat that trait, and that trait can be driven by anything. It does not matter. And that's in a couple of minutes I'm going to explain to you. So we know asthma is a heterogeneous disease. In pathophysiology, some of them have got a lot of inflammation, which is eosinophilic. Some have got a lot of parasympathetic activity, and some of them have got actually sympathetic activity. So, and there are several subtypes of them because of various kind of presentations, diverse clinical course, and of course the response is also not same in all individuals. So perhaps it is one of the best diseases which should be treated on the treatable traits. So what is a trait? The most important thing is that it is a feature in an individual. You identify that, you should be having some test to confirm that, and treat it. So that's called treatable trait. There may be untreatable traits like genetics, aging, fibrosis, which cannot change. So we cannot at the moment do anything, but they are traits because future may actually have answers there also. But at the moment we have treatable traits in asthma like fixed airflow limitation. Despite all treatment, shows his FEV1 over FVC ratio of less than 0.7, that is less than 70%. Then we have high eosinophils in the individual, and we also have patients who have got non-adherence. They just don't take treatment despite understanding that how important it is. So identifiable, it is measurable, and then it is treatable. So that's how we go and divide them into three main groups: pulmonary, extrapulmonary, and behavioral, or so called as risk factors in that. So let's look at a quick snapshot picture of what traits in asthma. We know that eosinophilic airway inflammation is very important. Airflow limitation, which is called fixed airflow limitation, because these people look like COPD patients, but they are not. Then exacerbation prone, who keep getting exacerbations again and again. A lot of people complain of mucus, that is called mucus hypersecretion. It doesn't have mucus. Only a couple of patients will come to you and say that there is a mucus coming, there is a mucus coming. They are mucus hypersecretor. Some of them are dyspneic all the time. Then there are some of them who have got neutrophilic airway inflammation, not eosinophilic, even in asthma. And small airway asthma, which Kanishk showed you. And that in fact 1/4 patients of severe asthma have normal lung functions, but they are suffering because of small airway disease, and our conventional inhalers are not able to reach small airways. So you need to identify the trait of the patient, and then you offer the treatment. Now first and the foremost treatment to an asthmatic patient, we repeat his lung functions. FEV1 FVC ratio is less than 0.7, which is a definition of COPD. Actually, you can easily label that patient of COPD, but it's called airflow limitation. It is infrequently because of the long-standing disease, but more frequently because exacerbations, airway becomes smaller, and stop responding to bronchodilators. So it's more or less a fixed airway obstruction. It could be because of eosinophilic inflammation or neutrophilic inflammation, airway remodeling, or destruction of the lung, parenchyma, or the airway wall. And in this, when you have a fixed airway obstruction in an asthmatic, we tend to use a lot of steroids, trying to reverse that airway obstruction. And that can lead to a lot of overtreatment and side effects. So you need to draw a line that this is a fixed airway obstruction, patient is asthmatic, I have tried steroids. Beyond this, if it is not improving, it has undergone a fixed changes which are primarily fibrosis related rather than smooth muscle related. Exacerbation prone is a trait of asthma. It could be because of eosinophils being very high in the blood. You can see the values 200, 400, or any value which is more than. Or it can be because of fixed airflow limitation, which we have already discussed because of remodeling, parenchymal destruction, airway destruction, and these are refractory to treatment, or mucus dysfunction, which I have already said. Then small airway disease is very important. These are like less than 2 micron in size, and they get clogged and they get obstructed very easily. Be it mucus, thick epithelium, thick smooth muscle, airway innervation, anything can cause these small airways to completely close, doesn't allow the air to reach the alveoli and the alveoli.
and causing these patients to be severely breathless, and spirometry is normal. So classic example was shown by Kanishk that spirometry is normal, but patient has a severe small airway disease which is causing a patient lot of trouble and requiring even admissions in the hospital with acute exacerbation. So this kind of small airway disease has been shown to occur in 90% of asthmatics, and it occurs in all stages, whether the patient is mild asthma, moderate asthma, severe asthma, in all of them. But as we reported that in severe asthma, nearly 1/4 of them have it. Then comes therapy. You just heard Kanishk talking about triple therapy in COPD. We are talking about triple therapy in asthma. You can see if you use inhaled corticosteroid, you can decrease exacerbations, you can decrease eosinophilic inflammation, and you can also address the small airway components of this kind of traits can be taken care of. If you add LABA to it, then along with it, it also affect airflow limitation by causing more bronchodilation. Also, it will be addressing the mucus hypersecretion. So if you have a combination, then obviously it will look at it many other points. But when you combine all three of them, you can see it can improve all elements of these treatable traits of asthma, and they can all be looked after by that. So it seems ICS, LABA and LAMA in asthma, it should be able to take care of each and every patient of asthma. But that I told you, it does not happen. And it does not happen because their expression is different, and the response to this triple therapy is not up to the mark in each and every patient. So LAMA is to be used in step 4 is a question. You can see Gina tells us to use it in step 5. But why? When it is it that the patients who are in step 1, step 2, step 3 are not prone to exacerbations or fixed airflow limitation? They are. Then if LAMA is the answer for them, why the LAMA is not to be added to them? Why is to be given? So any patient who has got a fixed airflow obstruction, is elderly, has got current or former smoking history, has severe exacerbations, cholinergic activity, women with patients with small airway disease, mucus hypersecretion, and those who have got neutrophilic airway inflammation are the candidates for LAMA in patients with asthma. So this is all irrespective of eosinophils, whether eosinophils are there or they are not there. If these are the characteristics of the individual, these are the people who require a LAMA to be added, irrespective of step 1, 2, 3. Now comes the eosinophilic airway inflammation. It generally occurs as asthma in late onset. They have a lot of eosinophils in the blood in the airways. They have some allergic symptoms which are minimal. And elevated IgE does not mean anything. If you find a patient who has got IgE raised and is a late onset, it is the eosinophil which is driving the disease, not the IgE, because that is irrelevant. And of course, they show poor response to the inhaled corticosteroids, and they have persistent T2 inflammation which needs to be blocked in this group of patients. So you look at this. The step 5 tells you add on LAMA. But is that step 1, 2, 3, 4 are not exacerbation prone, do not have small airway dysfunction, do not have airflow limitation? The answer is simple, no. We have shown in the clinical data. Then why not single in therapy for all these patients if they have these treatable traits? So we need to identify a treatable trait rather than actually the severity of that. And expected outcomes of using a triple therapy would be a good asthma control, good quality of life, lesser decline in lung functions, and less hospitalization. Now, beyond triple therapy, if patient has a T2 inflammation, what can you offer them? Montoleucast and azithromycin. Like Kanishk said about roflumilast and azithromycin. So roflumilast has been changed by something like Montoleucast here. Azithromycin is same. So you can use azithromycin in people who are not responding to your standard of care therapy in COPD or asthma. The difference is the dose. The dose in asthma is 250 milligrams 3 times a week, and in COPD it is 500 milligrams because mostly they are infective exacerbations in COPD and allergic exacerbations in asthma, where you need immunomodulatory effect more than antimicrobial effect for controlling repeated exacerbations. So these step 5 patients who have got everything, ICS, LABA, LAMA, continue to suffer with a poor asthma control, repeated exacerbations, and they have some kind of oral corticosteroids being given daily, or they have a high intensity treatment. They have everything on board. In our situation, we find they are on montelukast, they are on theophylline, they are on acebro, they are on N-acetylcysteine. So much of polypharmacy is going on. We really need to look for what are the alternatives. And alternatives are dependent upon the biomarkers. So do they show biomarkers? Because right now we have treatment for only eosinophilic kind of this asthma, step 5 asthma. And basically, if blood eosinophils are more than 300, FeNO is more than 20, or sputum eosinophils are more than 2%. We don't do sputum. So FeNO and blood eosinophils. But the important caveat to remember is all of them are exclusively sensitive to steroids. Even 5 milligram of steroid on the 300 eosinophils to like 50. And you may think that this is T2 low. Actually, there is no eosinophils, but it is because of steroid. So oral steroids, high dose inhaled corticosteroids, if the patient is already taking, 300 level has to be brought down to 150, and sometimes even 100 is also indicative of inflammation. We tried to look into severe asthma patients, that how do they look like in India? Are they eosinophilic type, allergic type, or they are like non-allergic, not eosinophilic, which is called T2 low. So we found that luckily about 95% of patients, 90% of severe asthma in India have actually type 2 high asthma. So they are responsive to treatments which are targeted to IgE or to eosinophils. But the problem is when we tried to put them into the grid of the 3 biologicals available in India, which is omalizumab, we found that almost 50% of them are eligible for more than one biologic, as per the labeling or as per the approval criteria by the authorities. So it becomes an onus on us to choose an appropriate biological for this patient. Whenever you see is a marker of exacerbations, marker of poor asthma control, marker of poor quality of life of these patients, and it is related to everything which goes to bad in the patients if they have a high eosinophil count. So we need to keep in mind. So we have biologicals which are available. What are biologicals? These are targeted missiles. So we target them with IgE. It goes into the blood, hunts IgE and neutralizes it. We target it for interleukin 5. It hunts for interleukin 5 in the blood through the various body organs, neutralizes it. And then we have an interleukin 5 receptor blocker. It goes and blocks the IL-5 receptor on the eosinophils. So when the interleukin 1 comes in there, it finds that, sorry, it's not available because it has been occupied by benralizumab. So nobody can degranulate eosinophils. And we know that you need eosinophils to produce eosinophilic inflammation. So some of them are not available, but 3, omalizumab, mepolizumab, and benralizumab are available. But you can see how many of them are coming, and they're going to change the picture as to how to treat asthma in a couple of years from now. So this is just a snapshot of trying to drugs which is better. So you will see that there is no head-to-head trials, but it does not tell us that any one is superior than other. All of them are able to reduce exacerbations in patients with asthma by 50%, and all of them are able to reduce the oral corticosteroid dose to 70%, and all of them are actually increasing the lung functions of the patient as well as quality of life. So it becomes very difficult unless and until you identify what is the driver of inflammation in that asthmatic patient. Is it IgE or is it eosinophil? So the most important part in that is IgE mediated is a childhood onset asthma. Somebody who dates back his history that I had symptoms when I was child, then I became little better, and then by the age of 30 I started having suffering again. Classical patient of the one which is IgE mediated disease will respond to omalizumab. have a history of allergic rhinitis. 20, 30 sneezes at a go in the childhood. They have urticarias and they have food allergies and they have nasal polyposis. If it all happens, classical patient who will respond to omalizumab. The other one is a little later onset after the they have high eosinophils, high pheno, and they have also chronic sinusitis, but they very importantly might have hypereosinophilia, they might have EGPA, eosinophilic gastritis, and these will respond beautifully to anti-IL-5 drugs like mepolizumab or benralizumab. Benralizumab has one more important aspect. It works much better even if the patients of asthma are little older in onset. They have more or less, it looks like FEV1s are very low, they will not respond, but they all respond once you have been able to identify if they have a lot of mucus on the CT scans. Mucus score on the CT scans, which tells us that this patient has a lot of mucus impaction, which is causing breathlessness in this patient, and will respond to benralizumab only. So are these drugs safe? So we have published both the papers of omalizumab as well as benralizumab. They are perfectly safe, more effective than what we have seen in the West, because in India we try to use it only when we have nothing else to use, and of course patient's pocket can afford the drug. So that's the biggest challenge which we face in our country. So this is where we are moving on now, not from one size fits precision medicine in asthma. I have discussed pulmonary components like limitation of airflow, eosinophils, recurrent infections which will require azithromycin, cough variant asthma, which is generally small airway disease asthma, mucus hypersecretors which can be taken care of drugs like sin, or even drugs like benralizumab, patients with respiratory failure who will require respiratory support. In the behavioral factors which need to remember, smoking, occupation, pollution, poor perceivers. Some of the patients, you know, they have so bad lung functions and they still say that I am all right, and they continue to suffer till the time they get acute exacerbation and get admitted in the emergencies in the ICU. Technique and adherence is a very important thing, because most of the patients suffer because they don't adhere to the therapy or they are not able to know how to use the therapy. And then something outside the lungs wall. So you can see anxiety, depression, and associated comorbidities like GERD, rhinosinusitis, cardiovascular disease, skin and food allergy, obstructive sleep apnea, obesity. All of them are equally responsible for making the life of a patient of asthma miserable. Asthma per se. So we need to identify each and every trait, because all of them can be identified and all of them can be treated. And that's how we are going to go forward, where each one of them which is listed here has a diagnostic criteria and of course a choice of treatment after that. What's the point of finding something which is you cannot treat it? So you should be able to diagnose it, and then you should be able to offer a treatment for that. And you can see that practically for all of them we have a treatment available, and even for behavioral and risk factors traits we have a treatment as well as a diagnostic criteria. So this is a snapshot of going to treat asthma. We are not going to treat them with ICS-LAMA. We are going to be looking for ICS-LAMA. And those who do not, we are going to look beyond the lungs. We are going to look for their behavioral factors, extrapulmonary factors, and if still we are not able to improve them, we are going to look for. So at the moment, 90% of patients are eligible for 3 biologicals which are available in India. Only 10% are not eligible, which will be the group which will be targeted in next 2 to 3 years with the drugs coming up. So this is a concluding slide of mine, which is trying to tell you that all asthmas are not same disease. And shifting the strategy from one size fits all to precision medicine is the way going ahead. In 2015, Barack Obama, when he took over as a president of United States, he actually gave $300 billion for precision medicine. I want that pharma should now invest in making medicines for individual patients, rather than making medicines for everybody. So change the perspective of earnings on the pharma to more importance being given to the patients. And he gave cystic fibrosis. He said, in my times, I have never seen a cystic fibrosis child surviving adolescence. Today, they are living the age of 30, 35, 40 because of the precision medicine which have been developed. There were only 5 monoclonal antibodies in 2015 in US. 150 developed in just 10 years because of this push which America has given for the precision medicine. So we are going to get precision medicine in every specialty, including respiratory medicine, and asthma has made immense strides in it. And this is how we are treating. So if I tell you that the largest center in India, which has got severe asthma clinic, as well as uses all biologicals. In fact, our omalizumab number is more than 1,000. Our benralizumab number may be more than 150 or maybe 200. Our mepolizumab number may be around 200 or plus. So these are the group using these drugs, and they are living an absolutely normal life. So life has changed completely. Thank you very much for this patient here.
Question answer session. Please stay for question answer session. I invite Dr. Sachant sir, and as a moderator, Dr. Bal Vikram Verma, Dr. Pawan Gupta, and Dr. Amit Gupta as panelists.
Dr. Pawan Gupta has got same look which he had 25 years ago. Has not changed even a bit. मैं आपको फॉलो करूंगा.
What about ABPA in the differential diagnosis are superposing to bronchial asthma, ABPA?
So ABPA is presently still considered as a complication in asthma, which is IgE mediated. And presently the standard is to use oral steroids and an antifungal agent, which is either itraconazole or a voriconazole, or even people have gone up to posaconazole because of the resistance which develops, the fungus develops it. It's not that the fungus is invasive, but it is causing allergy in the airways. Is that because of the steroid side effects, we are moving away from steroids and coming to only antifungals in this group of patients. I think your question is, can you use biologicals in that or not? So in 2010, we published in ATS and we presented the paper of using omalizumab in ABPA patients. And high dose, because omalizumab is to be given only up to the IgE level of 700, and ABPA is classically more than 1,000. So you have no dosage schedule to give. So we give 600 milligrams per month and try to give 600 milligrams twice a month. But at that point of time, the IgE 50 milligram cost was 30,000 rupees. So if the patient would have not died of ABPA, he would have died of the cost of omalizumab, which was available in 2010. So we did this for only 6 months, presented the data. After that, lot of people did lot of research on it. They also published it. And at present, the group in India, along with other countries, is doing 600 milligram of omalizumab twice a month. So that's the therapy which they are giving with antifungal for management of ABPA patients, where they are not giving steroids to them now. But I think poor men's treatment will still remain a small dose of steroids, which will be 10 milligrams.
Please tell us how to calculate the dose of omalizumab according to weight. Either we just go to 150 or 300, but according to weight, how we calculate?
So see, the IgE needs to neutralize IgE, and circulating IgE in the blood will require the weight of the patient and the level of IgE. So that is why the dose is calculated, because it is supposed to neutralize that IgE. So if it is insufficient, then it will be ineffective. So that is why the dose like appropriately done in those patients, where you need to have total IgE level and the body weight of the individual. So if somebody is like, God forbid, about 110 kg, then he will definitely lose weight because of the money he has to spend on omalizumab.
So you said the level of IgE
700 for using omalizumab. If a patient is having total IgE, say 400, so will you like to prescribe omalizumab?
Yes, we can. 400 is not a problem.
On what basis? Is it steroid dependent or something patient not responding with the steroid, ICS or oral?
Okay.
When you say the patient is not responding with the steroid.
I think very nicely you have asked it that IgE is not the only criteria. IgE is the criteria only to pick up the right dose of omalizumab. So patient who must show that IgE is the driver of disease in that patient. Comorbidities which are related to IgE like food allergy, skin allergy, urticarias, all these things are indicators that IgE is the culprit in that patient. And then second, the routine standard therapy which is given for that particular condition is not able to take care of that. So if it is like asthma and you are giving ICS, LABA and LAMA and the patient still patient's poor quality of life requires steroids to control the disease, then that's a patient who requires omalizumab.
When you say the patient is not responding with the steroid, ICS and oral.
Okay, so not responding to OCS or ICS practically means that this patient has got low inflammation, where these are not important at all, and there is a separate pathway which is being taken there. So in those situations, these patients are called steroid resistant, basically, but then steroids were never meant for them. So they generally effects of steroids, basically, because there's nothing else for us to give. We will give steroids because that's all we can give. So in such patients, if you ask me what is the answer available to us right now, so for T2 low asthma, which is what we are talking about, we don't have the drug which is available right now, which is dupilumab, effective, and the newer one which is coming, tezepelumab, which is perhaps the answer for all these kind of things in which there is no T2 inflammation, because it is an epithelial cytokine. So anything which has to come and attack the lungs has to come to the respiratory epithelium. Respiratory epithelium releases a hormone, TSLP. So TSLP will down when it goes into the epithelium and subepithelium, it will release interleukin 4, 5, 13, IgE, so many of them. But this TSLP is blocked by an anti-TSLP drug which is called tezepelumab, which will stop everything on the top, doesn't allow the cascade to come down. So that's molecule which is going to work even in COPD. So we are working very, very closely with this molecule, and hopefully in 2 years' time it will be the molecule to look forward to. Whatever is the disease in the patient, it will work.
The same Jumab and benralizumab target IL-5. If there is a level of IL-5 is less, then what will you suggest?
So see, IL-5 levels we generally don't do at all. We only do when the patients who look like IL-5 driven disease to therapy, because IL-5 will be sitting even on the eosinophils. So circulating levels may not be very reliable, plus of course it is not done routinely in the labs. So we go by what are the drivers of IL-5. So nasal polyposis, chronic sinusitis is a very strong, it is the eosinophil IL-5 driven disease. The second thing is eosinophil count of 400, 500, 600, 800, 1000 is an indicator that IL-5 is driving a lot of eosinophils into the blood. So FeNO is again one of the marker. If it is more than 20, 25, generally more. It is a driver again because of the eosinophils which are there in the airway. So we take it as a surrogate markers along with blood eosinophils to suggest that IL-5 is high, and you block the IL-5 and it will work. But let me tell you, whatever biologic you use, only 70% of patients respond, 20% of the patients fail. So they are called refractory through whichever biologic you are using. So you need to change the biologic.
So how long you use mepolizumab? And
so we generally, when we start, we give it for 4 to 6 months. If the patient says that I'm very good, that well, we will continue for 1 year and then decide after 1 year whether the patient's pocket affords it to continue, or we can space it. Instead of giving once a month, we will give it once in 2 months. If possible, if the patient's because we know that now the data has come that if at 1 year, after 1 year, you stop only 33% of people will relapse, 66% of them will do well.
Recent concept about the asthma COPD overlap syndrome.
So, sir, I will just say that from 10 till 2025, 15 years, 33 times this asthma COPD overlap has been defined. 33 times. There has never been any consensus, because if there was a consensus, there wouldn't have been need to define and redefine up to 33 times. And today, people say that asthma COPD overlap means either asthma happening in a smoker or a COPD patient who has got eosinophilic inflammation, which responds as good as asthma to mepolizumab and So, very excellent question, very close to heart of all of us. We do so much of work on it that it is a must for all patients of COPD to get influenza as well as pneumococcal vaccine. It is a must. Absolutely, it is indicated. Your API guidelines are very clear. All patients of both the vaccines. Absolutely, absolutely correct you are doing.
Thank you, sir.
Yes, sir.
Immunotherapy in bronchial asthma, particularly for house dust mite and food allergies.
Right,
because
sir.
house dust mite is
Absolutely.
common allergen to precipitate bronchial asthma.
So I will admit, sir, in front of everybody, that right from day one, if somebody has pulled me left, right, and center, is Dr. Subhash. And I respect him for that, because he always asked me the difficult questions, which he has again asked me today. So you are right, sir. Immunotherapy for HDM is approved not only in allergic rhinitis, but also in asthma. And I can tell you that by the end of next month, we are getting standard sublingual immunotherapy in India, which is going to be marketed. It is going to be available where we can easily tell the patient, buy the tablet from the pharmacy, come and take first tablet in front of us, and then go home and take it like that. Coming to food allergy. Food allergy is the most difficult thing to treat. And today, if you have multiple food allergies, there is something which is approved, which is omalizumab. And we have a doctor who's got very severe food allergy, and she's on omalizumab 600 milligrams per month, and she's doing very well. I think, Deepak, you saw her last time. Is she doing good now?
Yes, sir.
She's doing very well, actually. And this is the latest approval of omalizumab. And I personally feel it has allowed omalizumab not to get vanished. Because there is nothing else which is approved in food allergy. Omalizumab is the only one. Otherwise, you have to go for an oral immunotherapy, what you are saying. So oral immunotherapy for multiple food allergens can be only to one particular thing. So like peanut allergy. If you have peanut allergy, you will have a sublingual immunotherapy for peanuts. But if you have multiple food allergies, answer is omalizumab.
Role of hypothyroidism and vitamin D insufficiency.
Plenty of them in patients with of them, and actually you need to correct it, and it leads to significant improvement in quality of life of the patients as well as control of the disease. Check thyroid and vitamin D to all the patients of your asthma as well as COPD. Must.
It also prevents the acute exacerbations.
Absolutely, sir.
Sir, in small airway disease, you are talking about MDI inhaler and rotacaps and nebulization. Which is better?
So all have their own merits and demerits. I think the simple answer would be that whichever device is acceptable, best device actually. If we decide that this is the best aerosphere, it is such a highly technically advanced inhaler, I want to give it to all my patients, it won't work. It is ultimately, inhaler is the choice of the patient. You tell him, you discuss with him. If he is happy with that, he will continue. If he is not happy, No. But we know that children won't be able to use dry powder inhalers well. Less than 6 years, they need PMDI with spacers. But bigger children will be able to use DPIs equally well. Young adults are very happy in using DPIs. Elderly people, Parkinson's, patient with neurological diseases, and all other require a PMDI with spacer or nebulizer. So like all these devices have different indications in an individual patient. But there are so many people. For that instance, nebulizers are expensive because the drugs are expensive, maintenance is there. Many patients, we try to tell them that actually you can easily go to PMDI and spacer, and they say, no, we can't. So if the patient says no, and you put them, no, you can easily take PMDI, spacer or DPI, he'll not be happy. So ultimately, I think it is the patient's choice, which is the most important thing, which was never either in GINA or in gold before. But from 2023 onwards, every update which comes writes that patient's choice is equally important in deciding which device you are giving to your patient. So patient should be happy in using it. That's the most important thing, I suppose. Ji, sir.
What is the role of knowing the specific whether skin prick test,
Okay, sir. Sir, by and large, the skin prick test is the standard allergy testing technique because it's basically in vivo. What we are doing in blood is in vitro. So it may or may not correlate. We only recommend Phardia or ELISA or other tests in the blood when patient cannot undergo a skin prick test. And that is like conditions, patients on anti-allergics which cannot be withdrawn, things like that. So ideally it is the skin test, but now we have got a component test which is called molecular component test, which are available, which picks up like house dust mite, which one, DERPI 1, DERPI 2, DERPI 5, DERPI 10. We know DERPI 1 and 2 have got specific immunization schedule available and treatment available. So we are doing, after the skin prick test, the molecular diagnostic test in the blood to basically advise what kind of therapy which we are going to give it to them. If it is many DERPIs with significance, then the immunization is going to fail. It's little now becoming more advanced actually. Yeah, but sir, the mast cells are the same. Sir, mast cells are the same because they are all coming in circulation, blood, and reaching that even that thing. Right, sir. It is little cumbersome, I understand. So that's the reason why we have issues in doing it. And I don't think so that in a month we do more than maybe 20-25 allergy tests. Not much considering the amount which are there. So we don't do much also. I agree with you. A lot of hesitation also.
Efficacy of oral vaccine.
I've never used it, sir. I won't be able to say, sorry. I've never used it.
Nowadays, there is a lot on the integrated medicine. So do you have any experience with haldi, curcumin and piperine in reducing the inflammation of respiratory tract?
No, sir.
Sir, एक पेपर तो रिसर्च उस पे भी करनी चाहिए आपको.
Sir, I don't know, but whatever patient tells me that it helps him, I say, okay, take it. I don't challenge them.
Last question regarding pneumococcal vaccination. One shot of conjugated vaccine, that is 21, is enough, or it should be followed by polysaccharide vaccine after a year? Should be or should not?
So well informed that PCV 21 is coming to India very soon, and it will cover almost all the organisms which are there in that circulation. So it might be that after this 21, we will not be requiring a polysaccharide 23, which we are generally giving. So those patients who are very badly immunosuppressed because they are on immunosuppressive drugs, they are on rituximab, they are on MMF, they are on methotrexate, all those patients will still require an additional dose 1 year later of a polysaccharide vaccine, even after getting 21, getting 23, because there are many there in 21, but not there in 23, and many one which are in 23 are not in 21. So in severely immunosuppressed people, we will still use 2, but after the 21 lands up, which is expected in 3 months' time, the things will change as far as pneumococcal vaccination is concerned. Who can be more updated than physicians of Agra? They know that already 21 is coming. Even to us, Pfizer doesn't tell us so openly the release date of 21.
Please give a big hand. Deepak Talwar, interactive talk. I thank Dr. Deepak Talwar, Dr. Chairpersons, Dr. Sacha, Dr. Verma, and Dr. Pawan.
And I will again thank each and every one. I do not know how many were there when I said before that my entire life and entire journey from Agra, and it is continuing there. Thank you very much for being with me.
Next talk, I invite Chairperson Dr. Vandana Kalra. Dr. Vandana Kalra, please come and take the seat on the dais. This talk is on what's new in asthma and COPD exacerbation. The speaker is Dr. Deepak Prajapat, and panelists are Dr. Ashwin Yadav and Dr. Rajat Arora. Dr. Ashwin Yadav and Rajat Arora.
Thank you. Good evening, everyone. So today I come to know that why Dr. Talwar loves Agra people so much. So at 10:30 in the night, the hall is full, and still the doctors are listening us. So I will not take much of a time, and I will discuss about the what's new in the COPD and asthma exacerbations. So first, the new definition for the COPD exacerbation, it involves the symptoms, the duration of the symptoms, the signs, and the pathophysician which is responsible for the exacerbation. So in symptoms, we have a dyspnea and cough and sputum, which worsen within 14 days and accompanied by tachypnea or tachycardia, and often associated with increased local or systemic inflammation, and try to etiology, whether it's airway infection or pollution or other insults which are responsible for it. In the diagnostic approach, we have to look for the events which are life-threatening and try to rule out the other causes of which may mimic like a COPD exacerbation. And in these mimics, we have to rule out primarily the pneumonia, heart failure, and the pulmonary embolism. After rule out these three etiologies, these three diseases, we have to assess the symptoms, the signs, evaluate the severity of the patient on the basis of simple pulse oximetry, the saturation we measure, and simple lab test with the CRP levels, and if available, the arterial blood gas analysis, and try to establish the cause of the event, whether it's viral, bacterial, or cause. So this is the slide which showed the pathophysiology behind the exacerbation, whether it's bacterial, viral, or a pollution related. It ultimately leads to the airway inflammatory burst, which leads to the increase in the CRP level. And in the physiological pathophysiology, the expiratory flow limitation, and ultimately leads to the more and more dyspnea and respiratory failure. So when we categorize the severity of the exacerbation, we taken into account the symptoms, the signs, the respiratory rate and the heart rate, saturation, whether it's more than 92 or less than 92, and the CRP levels, whether it is less than 10 milligram per liter or more than 10 milligram per liter. So in milder category, we'll see the dyspnea, the visual analog score is less than 5, respiratory rate less than 24, heart rate less than and the resting saturation is more than 92, or if patient is already below the 90% or around the 90% saturation, whether there is a change of 3% or more than 3% is there. In the moderate category, if the dyspnea is visual analog score, respiratory rate is more than 24, heart rate more than 95, and resting saturation levels are less than 92%, and the CRP levels are less than 10. And if the ABG is available, the PO2 levels are less than 60 and the PCO2 levels are more than 45, which is normal, then we categorize in a moderate category. So out of these 5, the 3 criteria should be met. In the severe category, we only look for the ABG analysis and the above measurements which we discussed. If the ABG showed acidotic pH, these are the severe category of the exacerbation. Then we try to look for the etiology by doing the viral testing, sputum cultures, and the other tests just to see the severity of the exacerbation. And in the meantime, we try to differentiate from the other symptoms like heart failure, pneumonia, and the pulmonary embolism should be ruled out before labeling our patient is having a COPD exacerbation. So why exacerbation is so important? Because with each exacerbation, the lungs capacity is getting down and down. And if the patient is frequent exacerbations, then it ultimately leads to the early mortality in this subset of patients. That's why it's really important to see the correct phenotypes in these COPD patients who have a frequent exacerbations. So in phenotyping, types of exacerbation which are defined: the eosinophilic driven exacerbation, the bacteria driven exacerbation, and the frequent exacerbators. So what is unique about the bacterial driven exacerbation and the other frequent exacerbators? So there are markers which we are using to phenotype these patients, like the inflammatory markers, CRP, then the symptoms, the procalcitonin levels. So if the procalcitonin and the CRP levels are high, then it indirectly showed us that the exacerbation is basically a bacterial driven exacerbation, the use of antibiotics. So in all exacerbation, we cannot use antibiotics, but if the exacerbation is bacterial driven, then only the antibiotics will work better. So the duration of antibiotics in such patients should be of around 5 days, because with antibiotic in these phenotypes, the short-term mortality will reduce by 77%, the treatment failure reduced by 53%, and the sputum purulency will also reduce by the 44%. And the choice of antibiotic should be based upon the local resistance pattern in that. In the empirical treatment, we can prefer the aminopenicillin with the clavulanic acid, macrolides, tetracycline, and in selected patient, we can also use the quinolones, but after rule out the tuberculosis. Then why the antibiotic should all exacerbation? Because of the rising pattern of resistance in these subset of patients, and the latest data showed that in the ICUs, the patients who admitted with the COPD exacerbation in the South India, this study done, and they found that the Klebsiella, Pseudomonas, and the Acinetobacter are the commonest organism in the exacerbation, which are basically MDR and XDR organisms. So that's why it's really important to use antibiotics appropriately in the correct settings. Then the question arises, when the patient with the exacerbation came to us, at the time of discharge them on the nebulized medicine or on the DPIs. So the lot of our COPD patients have a very low PIFR rates. So if the PIFR rates are very low, then in these subset of patients, they are not able to take their DPIs properly. So which COPD readmit within 30 days is quite high in the DPI group as compared to the nebulized drugs. So after discharge in the frequent exacerbator category especially, the nebulized bronchodilator therapy is preferred over the other DPIs and the MDIs. apart from the pulmonary complication, there are certain extra pulmonary complications which are also responsible for these because of these exacerbations, and especially the cardiac events. And as per the data, all exacerbations, they are for a lot of cardiovascular diseases, and these cardiovascular diseases risk can persistent up to 1 year. So up to 1 year we have to chase these patients, and we have to keep them in close follow-ups. And those patients, especially those who have a severe exacerbation and hospitalization, the risk of developing the cardiac complications are much more in these subset of patients. So what will be the strategy for these group of patients? Whether we can use to call them in regular OPD visits, or we tell them to admit every time whenever they have symptoms. But just with the echocardiography and the anti-pro-BNP levels, we can monitor these patients, and we can prevent lot of cardiovascular complication if the patient of having exacerbations have more symptoms despite being on the optimal bronchodilator therapy. That if the patient with COPD exacerbation have out of proportion breathlessness, they always send to the cardiologist friends and for the evaluation of the cardiac part. Then question arises about the steroid use. So many of us feel that in the COPD exacerbation, a short-term steroids, it is not harmful for the patients, but the data showed that even the short dose of steroid therapy can lead to increase in the sepsis, venous thromboembolism, and more fractures in these group of patients. So the short-term steroid is not considered as, even in those patients who have frequent exacerbations, they receive multiple bursts of steroids during their hospitalization and even their OPD visits. So these are the group of patients who are at more risk of developing the sepsis, embolism, and the fracture risk. So what is the solution for? Now we have a data, the Agra trial, it showed significantly improvement in those subset of patients who have eosinophilic driven exacerbations. Whether they are asthma patients or they are COPD patients, doesn't matter. So what they did in this trial, they make 3 groups, and in one group they give the steroid alone, in the other group they give steroid with the benralizumab, and in the third group they give only the benralizumab, and compare all these 3 groups. The FEV1 at the exacerbation in the group is around 1.9 liter. In Benra group also 1.8 liter. In the Benra plus prednisolone group it is 1.7 liter. So it's almost same range of lung functions in these 3 groups. The biomarkers they use, the blood eosinophil and the FeNO levels, as discussed with Sir in the previous lecture. Just like COPD also, if the eosinophils are the main driver, we can use and we can think about the use of biologicals in these subset of patients. And in the symptoms, when they compare the common symptoms like cough, dyspnea, wheeze, sputum purulence, sputum production, these are all common symptoms in all these 3 groups. And they saw that the events after starting the benralizumab, the exacerbation events are much less in those groups where they give the benralizumab compared to those groups who received only the prednisolone, the steroids. So this is a summary of that number of patients with the treatment failure at 90 days is around 74% in the prednisolone group. In the pooled Benra group, the failure rates are quite low, that is 45% as compared to the prednisolone alone. When they compare the symptom score is also improved in the pooled Benra group as compared to the prednisolone group. And when they look after each individual symptom is also improving much better in the benralizumab group as compared to the prednisolone. And all these values are statistically groups of patients. So the nutshell is benralizumab is a new ray of hope for patients with eosinophilic endotypes in obstructive airway disease, not COPD, not asthma, but in obstructive airway disease during exacerbations. Thank you so much.
dais Dr. Anvi Tyagi. And panelists Dr. Atihash Mohan Agarwal and Dr. Sushant Dhawan. I request Dr. Sunil Bansal and Dr. Naveen Jamneja, please take the seat as a panelist. Dr. Vanna Kalra.
No, sir. No. Even now, in the group of patients who have exacerbations, frequent exacerbations, the statins are indicated just to reduce the cardiovascular events.
So what should be the duration of antibiotic therapy in purulent sputum exacerbation of COPD?
So generally, as per the guidelines, it is recommended for 5 days. But if the underlying lung disease or structural lung disease is there, then we can extend the duration of antibiotics depending upon the response of the patient, the clinical response.
Should the sputum culture be sent routinely before starting antibiotics like in other infective disease?
Yes,
Or
ideally
should be
yes,
empirical
because
therapy?
yes, ideally there are increasing incidences of the drug resistance bacteria. As we showed in the South Indian studies also, they mentioned that now the Klebsiella, Pseudomonas and the Acinetobacter, these are the commonest organisms which they grew in the cultures of the COPD exacerbation patients.
Our teacher, Professor Anil Patni, during winters in COPD, who had frequent exacerbation, used to prescribe bi-weekly doxycycline or ciprofloxacin during winters. Is it relevant?
So nowadays,
for
sir,
prophylactic antibiotic?
Nowadays, because of the increasing chances of tuberculosis, the quinolones, but the macrolide should be given.
Prophylactic bi-weekly?
Yes, yes. If the patient is having more symptoms, and during the winters, if every winter they develop the symptoms, they can give prophylactic also.
Does the color of the sputum give some direction to choose?
Yes. In India, it makes sense because there are a lot of other environmental factors which are responsible for these exacerbations, not only the bacterial ones. Sir, it depends upon the response of the patient, but generally, if prophylactic, it can be given up to 1 month, but for those patients who have underlying lung disease like bronchiolitis or bronchiectasis, in those subset of patients, we can use it up to 3 months or 6 months. 3 times a week. No, no. Basically, if we want to use the quinolones, linezolid. So generally, being a chest physician, we are not more keen to use the linezolid.
It is very commonly used nowadays. Many prescriptions I am seeing. This is reserved for MDR team.
Yes.
That is for BPL.
Yes.
Should not be used.
It should.
So most of the patient tuberculosis, they are also having COPD or asthma. And then how to use the steroid judiciously?
So, sir, those patients who have active tuberculosis, in those subset of low dose of ICS, but in those patients who have old history of tuberculosis, we can use high dose of ICS in these subset of patients, but we have to rule out active tuberculosis before starting the inhaled corticosteroids.
Regarding you said short-term usage of steroids is not indicated. So my question is, which steroid will you be using, and for how long you will be using it?
So, ma'am, generally in the COPD exacerbation, we are using short-term of steroids. Till date, we have only now, recently the Agra trial came, which showed the eosinophilic phenotype showed improvement with the benralizumab. But if the patient is not having a eosinophilic phenotype, then in the other exacerbators, the thing which we can offer them, and along with the antibiotics like macrolides. So generally we give 5 days of oral or IV steroids in these subset of patients, the methylprednisolone preferably.
Which biochemical marker predicts mortality in an acute exacerbation?
So
something like CRP.
CRPs are basically does not indicate the mortality itself. CRP basically showed that there are inflammation in the airways, and we have to use the antibiotics early in these subset of patients. If we are talk about the biomarkers, then I think it is having a more relevant from the card. If we use the NT-proBNP and the 2D ecography we use in these subset of patients, which can predict the mortality in these frequent exacerbators. Because most of the times we ignore the cardiac side and we just focus on the pulmonary point of view. So in these, now they showed that in these frequent exacerbators, the risk of cardiac mortality is much higher, up to 1 year. So we have to follow up these patients carefully by using these biochemical markers.
Last question, if given IV steroids, which particular steroid will you indicate? Steroid for
we are
5
using
days.
methylprednisolone.
But in diabetic patient, it causes a lot of problem. The next day we get sugar readings of 400.
So in those cases, we can use prednisolone even.
So any other questions? Yes, Dr. Vishwani, we close. So thank you so much.
Thank you, Dr. Deepak Prajapat and chairpersons. In the end, we have the case discussion on DTA. I invite Dr. and Dr. Kanishk Singh again for a case discussion on DTA. Dr. Talwar.
So we'll be running this case very quickly, and for the panel discussion, I would request Dr. Prashant Prakash to be on the stage, please. And I think he's not here. So I request Dr. S.K. Madhukar to come on the stage for the discussion. So let's start with the case. This case is of Mr. NS, BMI 26. He's a 55-year-old male, chartered accountant, and has been having episodic shortness of breath with wheezing since last more than 20 years, which has increased since last 6 months. Never smoker, no history of any irritants or biomass fume exposure, takes alcohol 60 to 120 ml per week. Symptom with worsening during rainy and spring season is present. There is recurrent history of running nose and sneezing with change of temperature. History of increase in symptom on exposure to dust is present, and smoke and kitchen fumes. If you talk about smoke exposure, none in last 25 years. There is presence of allergic rhinitis. Stop bang is 2 out of 8. Chronic rhinosinusitis is present. The patient also has severe GERD. So there are very significant points. CA, history of wheezing, and seasonal variation is there. Of course, a history of running nose, chronic rhinosinusitis is present, GERD is also present. Now we move further. There is history of recurrent acute exacerbation since last few years. This case was taken before, so 2007, requiring oral corticosteroid bursts 5 to 6 times a year. Each burst lasted for 7 to 14 days, 3 to 60 milligram per day. ACT score was 16. The current medication, the patient was on PMDI formoterol, budesonide, 400 micrograms twice a day, with PMDI tiotropium micrograms once daily, and on montelukast. There is history of multiple course of antibiotics for viral or maybe pollution-related exacerbation. Adherence. The patient was compliant and adherent to the whatever medications he was prescribed to. This is a chest X-ray and the X-ray of the sinuses. Lung functions 2010 showed FEV1 of 38%, 1.08 liter, and percentage change was 60 ml. So the patient was added with the drug doxycycline 650 milligram, half tablet daily, nasal corticosteroid spray, plus fexofenadine was added. The patient was also given PPI and H2 blocker because there was a history of GERD as an anti-GERD measure. So how would you proceed further in this case? So.
Hi, Kanish. This seems to be fairly enough a case of uncontrolled asthma, which is severe, which is not difficult to treat. So actually, it's a case of severe asthma. Now, at this point of time, when the patient is having a good compliance, comorbidities are addressed, and the patient is already in moderate to high dose ICS, this is the right time to phenotype the patient. I would like to have at least FeNO, an absolute blood eosinophil count, to be done so that we could know that whether this patient is having Th2 high asthma or not.
Perfect. So we did test which was negative. Immunocap assay was done for aeroallergens, which was positive for house dust mites. IgEs was 430. Absolute eosinophil count was 872. Sputum analysis was not done. FeNO was not available at that point of time when the patient came, and FEV1, as we discussed, was 38%. ACT score was. So as you said, it is not a difficult to treat asthma. It is severe asthma. So how would you further proceed with this case, and what would you recommend further in this case?
Clearly the phenoendotype. Are you asking me this question, or this question goes to the audience?
Of course, if somebody wants to add, but I know everybody is tired, and maybe I request you to answer.
Okay, so the phenoendotype has been done, and we know that this is Th2 high asthma. Now, at this point of time, when we are exhausted with all the resources that we have, options, the pheno has not been done. Either we can go with the non-phenotype based treatment, whether we'll have triple therapy for the patient, or we'll go for the biologic. As we are hearing constantly, our mentor, Dr. Deepak Talwar sir, is telling us to have a targeted therapy, to have a treatable trait identified therapy. The best choice at this point of time would be for me to choose a biologic. So how would I choose the biologic in this case? The first, the patient is not having childhood onset asthma. The patient is having adult onset asthma. So this is the first thing. The second thing, the patient is oral corticosteroid frequent burst every time, requiring 2 weeks of the treatment, at least 5 to 6 times per year, means every 2 months. So patient who is highly oral corticosteroid dependent asthma, having adult onset asthma, one biologic that I effectively would rule out in this case is omalizumab. So what choice here is either anti-IL-5 or anti-IL-13, but anti-IL-13 I wouldn't go because pheno is not been done. So for me, in this case, will be either mepolizumab or benralizumab.
That's a perfect explanation, but this was the year 2011 and 12.
Understand, but in the present context, I would say, yeah, the adult onset asthma, which is not childhood onset asthma, adult onset asthma, though it is allergen driven, but it's adult onset asthma, which is highly oral corticosteroid dependent. These two features in present context, would give me either mepolizumab or benralizumab, the first one to try in this case.
So this was the year I said this, to 2011, and the patient was started on omalizumab 300 milligram twice a month, because that time benrali and mepoli was
Fairly enough in this molecule.
Yeah. So the patient was started on omalizumab 4 months. The patient has partial response and continued for 1 year. There was 30% improvement and 25% reduction in acute exacerbations requiring oral corticosteroids. So this is the lung functions of 2010. We already discussed that it was 1 liters, 38%, which changed to 57% and 1.63 liters in 2012. Now, the patient left omalizumab 1 year with the mutual, after taking 1 year with the mutual consensus, and at that time we had an option of bronchial thermoplasty as well. Comfortable with the option of bronchial thermoplasty, and 2012 to 2019 passed. There was a use of repeated oral corticosteroid with the development of cataract to the patient, and the patient underwent surgery in both the eyes. The AEC at that time was around 4, and the patient was on oral corticosteroids as well. This is 2019. What would be your advice to the patient on biologicals?
See, your patient has discontinued it, taking it. I mean, any discontinuation of biologics should be considered only after at least 12 months of therapy. The patient has not been compliant enough on the biologics, and we don't know how long the patient would require biologics. So whenever your patient is on biologics, it is important to monitor the response after 4 months, at least after 4 months of the therapy, with the patient's symptom exacerbation, the development of fixed airflow limitation that has already occurred, and the last one is the blood eosinophil or FeNO. So this clearly indicates that the patient requires reintroduction of biologics. Perfect. In this case.
That's what we wanted to discuss, that the patient requires the reintroduction of biologicals, and the patient was started 100 milligram once a month in September 2020. 6 months, the patient had good response and continued for 2 years, 90% improvement, and off oral corticosteroids after 1 year, and off doxycycline as well. But the patient developed glaucoma, and I consultant, the ophthalmologist, us to reduce the inhaled corticosteroid dose as well. This was the lung functions on mepolizumab. Here you can see in 2020 1.63 liters, 2023 1.97 liters with 69% FEV1. So what would be to this patient now? Can this patient go off inhaled corticosteroids? What else is remaining and what else can we do?
Yeah, the notion is that if the patient should at least be maintained on at least medium dose ICS when we are thinking of withdrawing, when tapering or increasing the duration of the biologics in the case. Here, the patient has developed glaucoma, the patient has developed cataract. So this, and the patient on mepolizumab is well controlled, absolutely well controlled at the end of 6 months. So this is the case where we should definitely think of, removing ICS from the algorithm. So I think this is the case where we should definitely consider removing ICS from the algorithm.
So we had another option which was left, which is switching the patient to benralizumab, and then we switched the patient to benralizumab 30 mg once in 2 months. 3 years on, the patient was on low dose ICS, and LABA was used on SOS basis only. So this is what we do. We try one biological. We think that if the further improvement is required, we can switch to IL-5R and IL-5R to IL-5 as well. Thank you. Thank you, everyone.
Thank you.
So I request Dr. Deepak Prajapat to take the stage for the felicitation ceremony.
So I request all the faculty members to be inside the hall. Devinder ji, can you call to come in the hall? So I would like to request Dr. Subhash, please be on the stage. I request Dr. Talwar sir to please felicitate Dr. Subhash. I request Dr. Sachan. Dr. Vandana Kalra. Gopi. Dr. Vikram Verma. Bal Vikram Verma. Yes. Dr. Ranveer Tyagi. Dr. Vipul. Dr. Anukul Jain. Dr. Rajiv Kishore. Dr. Vipul. Dr. Anukul. Dr. Rajiv Kishore. Dr. D.P. Agarwal. Dr. Sanjeev Anand. Dr. D.P. Agarwal. Sanjeev Anand. Dr. Rajesh Gupta. Dr. Pawan Gupta. Dr. Amit Gupta. Dr. Ashwin Yadav. Dr. Rajat Arora. Dr. Mohan Agarwal. Dr. Sushant Dhawan. Dr.
सबको भिजवा देंगे.
I think after dinner. So we'll. So thank you everyone. On behalf of PACS, we would like to thank all of you and our educational partner, Astra. Thank you so much.